Welcome to this Clinical Explainer. Whether you're a seasoned practitioner or an ambitious medical student, we're about to step onto the ward for a really vital clinical masterclass.
Welcome, doctor. Pull up a chair. Today, we're going to master chronic lymphocytic leukemia, or CLL. Now, I don't want you to just memorize a bunch of lists. I want you to truly understand how this disease behaves. That way, when a 72-year-old patient sits in front of you with some abnormal blood results, you'll know exactly what to tell them, what to look for, and exactly when to act. Let's get to work.
So, imagine you're sitting in your outpatient clinic. Your next patient is a 74-year-old gentleman who feels perfectly fine. I mean, he just had routine bloods done for his annual checkup, right? But his white cell count comes back at 45 times 10 to the power of 9 per liter, mostly driven by lymphocytes. Now, he's sitting across from you and he's absolutely terrified because the word leukemia is stamped right on his chart. You've got to know how to handle this because CLL is actually the most common form of leukemia found in adults in Western countries. You are going to see this frequently. You really need to know when you can confidently tell the patient, hey, we're just going to watch this, and when you need to act urgently to save their life.
Okay, let's dive into our agenda for today. We'll start with the core concept, then build a 4-step mental model, run through some real-world patient cases, and finally, lock down real-life management.
Let's jump right into Section 1, the core concept, where we'll break down the pathophysiology like a professor.
I want you to think of CLL as a factory, but this factory is producing an army of soldiers that completely refuse to die, and yet they're utterly incompetent at actually fighting. So CLL is driven by a monoclonal proliferation of well-differentiated lymphocytes. Normally, your B cells have a set lifespan. They do their job, they undergo natural cell death or apoptosis, and they produce useful antibodies. But CLL B cells, they just don't undergo that normal cell death. Instead, they accumulate, clogging up the blood, the lymph nodes, the spleen, and the bone marrow. And here's the real catch. Despite having billions of these B cells, they're completely dysfunctional. They fail to produce useful antibodies, which leads to a state of hypogammaglobulinemia, leaving your patient totally vulnerable to bugs. Sometimes these confused B cells even start producing autoantibodies against the patient's own blood cells, setting off some really nasty autoimmune complications.
And what kind of cells are we dealing with here? Well, 99% of the time, those monoclonal, well-differentiated lymphocytes are B cells. That's a specific statistic you'll definitely want to keep in your back pocket.
Moving on to Section 2, let's shift gears and look at the 4-step mental model. This is your reliable algorithm for triage. When you suspect a case of CLL, I want you to approach it sequentially with this 4-step mental model. Step 1. Spot the demographics and clues. You're usually looking at an elderly patient. The median age is around 72, and they're often totally asymptomatic but presenting with a high lymphocyte count. Step 2. Confirm the diagnosis non-invasively. Step 3. Screen for what I like to call the 2 deadly eyes. That's infections and immune complications. And finally, Step 4. Decide to act or wait. If they're asymptomatic, we observe. We really only pull the trigger and act when there's progressive marrow failure, massive nodes, massive splenomegaly, or severe systemic symptoms. And this brilliantly illustrates Step 2. Look closely at this peripheral blood film. Do you see those fragile, disrupted cells scattered around? Those are smudge cells or smear cells. Because these leukemic B cells are so abnormally fragile, they actually get crushed when the lab technician physically spreads the blood across the glass slide. Spotting these artifacts is your classic immediate visual clue that you're dealing with CLL. Now, to finalize that diagnosis, listen carefully. You do not need to jab a needle into their hip. A bone marrow biopsy is absolutely not required for diagnosis here. Instead, you just send peripheral blood for flow cytometry or immunophenotyping. This is your most valuable test, hands down. You're looking for clonal B cells that uniquely co-express CD5, CD19, and CD23. Once you've confirmed that, you move right to Step 3, screening for those 2 deadly eyes. That's infections, thanks to those low immunoglobulins, and immune complications like warm autoimmune hemolytic anemia or immune thrombocytopenia. All right, Section 3, real-world patient cases. Let's see how well you can apply this framework. Here we go with Case 1, the incidental finding. Notice the presentation here. A 70-year-old woman presents with a painless swollen lymph node in her neck. Her routine bloods show a lymphocyte count of 20, but she feels absolutely fine. So, here's the key question for you. How do we prove this is actually CLL and not just some lingering infection?
Well, if you followed our mental model, you know exactly what to do. You'd check a blood film, fully expecting to see those fragile smudge cells.
Then you'd order flow cytometry, specifically looking for CD5, CD19, and CD23 positivity. And if it's confirmed, because she's entirely asymptomatic, her management is simply an observation policy. We wait and watch. You just reassure her and you keep an eye on her bloods. Easy enough, right?
Let's move to case 2 and see how this builds. This is the autoimmune crisis. Notice the shift in severity here. A 68-year-old man with known CLL comes into the A&E. He's dizzy, he looks jaundiced, and his hemoglobin has suddenly plummeted from 130 down to 75 grams per liter. The key question: what on earth has his CLL triggered? Look at the Coombs test.
The Coombs test comes back positive. He's developed one of those deadly eyes, an immune complication known as warm autoimmune hemolytic anemia, or AHA. You definitely do not just watch and wait here. The initial intervention of choice is a steroid, specifically prednisone. And if that happens to fail, your second-line step is the monoclonal antibody rituximab.
Finally, let's look at case 3, the rapid progressor. Notice the systemic breakdown in this patient. We have a 72-year-old man with known CLL who reports extreme fatigue, drenching night sweats, and he's lost 12% of his body weight in just 4 months. On examination, his lymph nodes are massive and bulky. So does he meet the criteria to abandon that watch and wait strategy and start chemotherapy?
Yes, he absolutely does. He has severe systemic B symptoms and rapidly progressive disease. You need to act now. The initial treatment of choice for the vast majority of these patients is FCR. That's fludarabine, cyclophosphamide, and rituximab. But wait, here is a critical, literally life-saving detail you cannot forget. Fludarabine carries a significantly high risk of opportunistic infections. You must start him on cotrimoxazole prophylaxis to prevent pneumocystis jirovecii pneumonia while he's undergoing treatment.
Okay, bringing it all together now. Section 4, real-life management. Let's summarize the actions.
So, the crucial point is summarized right here. Let's lock in this mental map for the clinic. For your early stage, asymptomatic patients, you employ an observation policy. Basically, you wait and watch. But the very moment they flip to progressive or highly symptomatic disease, we're talking massive nodes, dropping hemoglobin from marrow failure, or extreme systemic B symptoms, you strike back with FCR, fludarabine, cyclophosphamide, and rituximab.
But before we wrap up, I want to highlight a really sobering reality straight from the clinical data. Take a look at this quote. Infections are the most frequent complication causing death in patients with CLL. It all comes right back to that core concept we talked about earlier, the hypogammaglobulinemia, that useless army of B cells that clog up the whole system but can't even fight off a simple bug.
So, as a clinician, your job isn't just about managing a white blood cell count. You can treat the cancer, sure, but are you prepared to catch the deadly infections before it's too late? You absolutely must remain hypervigilant about these secondary risks. Screen for those infections, manage the immune complications, and always treat the whole patient. Thank you for pulling up a chair today. Keep this mental model sharp, and you'll be ready for whoever walks into your clinic next.